So, you guys have probably experienced this in all your bio classes. Maybe you never thought of it this way, but when we study these things, we decide to put them in categories. We create labels, but they're somewhat made up labels, right? And for the most part, the labeling convention stays. Every now and then things change, but the tissue itself doesn't care what label or what classification you put it. Okay, so they're somewhat arbitrary, but you have to know them because that's how the field has decided to characterize. So the way that we characterize these is, this is not doing what I want. The way that we characterize these, there it goes, okay, is based on different types of attributes that we see in the different types of necrosis. And there's certain features that we pay attention to. So there was a question on the quiz about coagulative necrosis. And so we're going to look at coagulative necrosis a little bit more in depth. But coagulative necrosis is really kind of described by the pattern of the damage. And so if you look at tissues like heart, tissues like kidneys and the adrenal glands, they have this vascular architecture that's like a tree or a root branch. And so if you block off blood flow to the top part of that tree, the result is damage in that entire area that tree would perfuse, and usually it starts looking like a wedge. Okay, so most oftentimes, you can see two different wedged lesions in this example. Right, so this is a spleen, so you can add spleen to the list. And in this splenic infarct, this patient was at risk of developing splenic infarcts and had two. The one that's lighter in color, right, that one's older. The remodeling is more complete. It's a fibrotic scar, not too dissimilar from a fibrotic scar on your skin. Okay? And the sort of darker colored one, right, sort of at 6 o'clock, right at the bottom, that one is a more fresh splenic infarct. But it has this architecture of a wedge shape. And you're getting a tremendous amount of protein denaturing taking place because you've lost blood flow. And as the blood flow decreases to the tissue, you lose oxygenation. And that changes the shape of the protein, and it starts to denature as it starts to essentially spoil. Coagulative necrosis is usually secondary to acute ischemia, unless it goes in that blank. What that fancy sentence is saying is, first comes a loss of blood flow or acute ischemia, then comes coagulative necrosis. So it's secondary to the primary cause, which is acute ischemia. Grossly, the tissue is usually firm, okay, pale, and clearly defined. Very, very distinct borders. Fibrosis is just a fancy word that we'll continue to use throughout the semester that means a scar. And that's what you're looking at. So, in the exam, if you saw this picture, you would know it was a splenic infarct. You would know that it's a type of coagulative necrosis. You might see a multiple choice question about kidney or heart, adrenal glands, or the spleen, all being subject to coagulative style necrosis. So here's some histological examples. This is an infarcted kidney. This is off the digital DVD. Again, you don't have to buy it, because if I'm going to test on it, you're going to see a picture like this, something that I went over in lecture. So all of these round structures that you see are all necrotic. So we've zoomed in into the wedge, and we're looking at all of these glomeruli, and they're all infarcted, they're all dead, they're all scarred over. Here's what a normal kidney looks like. And you can see that the glomeruli are nice and delineated. Here they are side by side. So you can kind of appreciate the difference between an infarcted kidney on the right and a normal kidney glomerular architecture on the left. Okay? Second type of necrosis, liquefactive. Who made up the name? I don't know. I don't have the detail. I'm not sure. Okay? But liquefactive tends to target neurons and glial cells of the brain. There's a lot of hydrolytic enzymes that get released out of neural tissue. And those hydrolytic enzymes and the lipid content interact, and it creates kind of a mushy tissue. And that's where it gets its terminology of liquefactive. In some cases, you might actually see pus if there's a pyogenic bacterial infection. But not always is that the case. Sometimes you might see that. Okay. Characteristics, it's irregular. It's not delineated like you saw with coagulative. It's usually round or ovoid, oval-like, but it's very much often irregular in shape. It's not a clear, defined area. There's, if you do a biopsy of that tissue and you section it, a lot of times the tissue integrity doesn't stay in place, and so you don't get a complete section. There's like a spot in the middle of the tissue that just falls away when you cut it. One second. In this picture, we're looking at a section through the brain, right? So this is the right side of the brain, this is the left side of the brain. We're coming down from the top right here, right? A coronal section from the top. And you're looking into the lateral ventricles, so the right lateral, the left lateral, and then the third ventricle. And this is liquefactive necrosis up in the upper left hemisphere. Okay? Okay, questions?
You said that the hydrolytic enzymes interact with what to get the mushy texture?
A lot of the lipid content that's found around the neuron, like the myelinated sheaths.
Is this common in both the peripheral and the central, or is it more?
Yeah, it's common. It would be found in both the periphery as well as the CNS, but most oftentimes in the central nervous system. You just have the most dense collection of neuronal tissue in the CNS. All right, caseous necrosis. This one's pretty disgusting, to be honest. All right, it's kind of a combination of coagulative and liquefactive. It looks like mushy cheese. We see it oftentimes in tuberculosis. The tissues themselves, as the dead cells disintegrate, the debris is not digested completely by the enzymes in the tissue, like what you see in liquefactive. So it leaves some of that cellular debris present. That's why it kind of has this kind of like cottage cheesy look to it. So these pictures are showing a tuberculosis infection. You can see the lesion right here on X-ray. You can see a nice infection in a lymphatic nodule in the lung, and then you can kind of appreciate the necrosis itself of the lung in this upper image. Fat necrosis. This is an interesting one. It usually is targeting tissues that have a high fatty content, like breast tissue, pancreas, a lot of abdominal organs. There's a lot of enzymes or lipases that are present in fat tissue to break down the fat, recycle the fat. And what you're looking at is fat necrosis with these kind of nodules of necrotic tissue that kind of look like these little stones that are scattered, these light-colored stones. Like here's one right here, here's one right here, here's one right here, okay? And what takes place is these lipases that are found in these fatty tissues, they digest the triglycerides. Those triglycerides form free fatty acids that bind with calcium that's nearby. Calcium in the presence of magnesium and sodium form a compound that can become saponified, and it basically is like bar soap. So these little nodules are saponified fat. And like ivory bar soap is hard, that's what they feel like. And fat tissue is very soft. Okay, so saponified fat is found in these fatty tissues. Now, interestingly, as we age, our tissues change. As women get older, the composition of the breast becomes a little bit more saponified. Some women are more predisposed to fat necrosis of the breast tissue, and oftentimes it's misdiagnosed as being a lump, okay, on self-examination. And so some of these lumps on self-examination that move on to imaging, or maybe even to biopsy, and everyone's freaked out, and the woman comes back and says, oh, I just have like lumps in my breast. I guess it's sort of normal, what the doctor tells me. This is what's happening. Okay? So there are certain individuals that are more predisposed as they age, developing saponified lesions in fatty tissue. And if you palpated the pancreas, which you don't normally do, you'd probably find something similar to this. But there's not a lot of tutorials on pancreatic self-examination. Okay? So we don't have any, false alarms like we do with breast examinations. Okay? But the normal process is self-examination for the woman after certain ages, or if there's certain medical history in your family, and then it moves on to imaging. Okay? If the imaging looks like there might be something there, then we move on to biopsy. Okay? But just kind of giving you an example of what happens due to a pathology known as age. Remember we talked about that? So this is part of the aging process. Okay? All right, gangrenous necrosis. Someone walked in, no, it wasn't my office hours, but I think the slide was on the screen while I was eating my lunch, and someone knocked and said, oh, no, it's not office hours, but I asked you a question. And maybe it wasn't this, it was one of these pictures, but I was eating pistachios while I was looking at this, preparing for this class, and I thought, how odd, because some of these pistachios look a little dark. So pretend that these are Keller's pistachios during lunchtime, but this is more of a clinical term, okay? But so in pathology, a lot of times we kind of meld the two fields of like clinical medicine and scientific study. And so coagulative necrosis, liquefaction necrosis, fat necrosis, all of these are types of scientific categories. And they get into the category of gangrenous, and it's really more on the clinical side. Okay? But let's talk about it. So we've got a couple of different types. We've got three that we're going to describe. Dry gangrene is a result of coagulative necrosis that usually takes place. Okay, so again, you're losing blood flow into the tissue, and wherever that blood flow tree was going to perfuse now goes dead. Okay, but the tissue shrinks and goes black or brown, like what you see here. That's dry gangrene. It would be accurate to call it coagulative necrosis, because it's usually because you've lost blood flow. And it often happens in exposure, okay? Hiking in extreme, or being out in extreme conditions. Now, wet gangrene is usually targeting internal organs. And it happens when a lot of the neutrophils invade the dead tissue. And when the neutrophils invade the dead tissue, they start to break down that tissue even further, and it's like a liquefactive necrosis. And usually the internal organs are now swollen, they're cold, they're black, they have a foul odor, and there's probably pus, because there's bacteria that are present, especially if it's like cold. So if you have intestines that are gangrenous, usually it's like a wet gangrene. The last one is gas gangrene, and this one is really referring to anaerobic bacteria that are present, and the bacteria release toxins and hydrolytic enzymes, and you start forming these little gas bubbles. Okay, so 3 different variations of gangrene. Dry being most similar really to, or being actually coagulative. Wet gangrene really being like liquefactive necrosis. And then gas just referring to an infection. But clinically, when we look at these things and we see skin gangrene, this would be a dry gangrene. Here's normal plantar skin on the left. Okay, again, these are examples out of the histology DVD, but you don't necessarily need, if you want to study for the exam, you just want to study these lectures, because those pictures are here for you. Okay, and then we're going to explain them. So this is normal plantar skin, right? So let's say this is like at the bottom of the foot, because this is the epidermis here. And you see this little light purple layer? That's the stratum lucidium layer. So this is thick skin. You guys remember that stratum lucidium layer or lucidum layer? And as you move more deep, this is our stratum basale layer. And this box is the dermis. Okay? So if you were to look at this dermal tissue, you would say, okay, that looks nice and healthy. It's nice and pink. There's a lot of there's some white open spaces. We've got a gland right here, right? We have vascular supply. And if you look at a similar area, but in a gangrenous piece of skin, you see complete disorganization of the skin dermis. We've got mostly inflammatory cells that are present, and they're mostly neutrophils at this stage. And all of the neutrophils can be evidenced by these dark purple dots, which looks like the whole screen, okay? But like on my screen here, probably on your screen at home versus the projector, there's actually punctate nuclei throughout that entire tissue. And over here, you see a few purple dots, but not nearly at the same level when we magnify a piece of gangrenous skin. Okay, questions? All right, we're at, okay, question, yeah?
Yeah, in the caseous necrosis, it's a combination of what and what?
Caseous necrosis,
Yes.
liquefactive, and coagulative. All right, this is the point in the lecture that I alluded to that we're going to start talking about mechanisms, okay? And we move deep into the cell to talk about kind of like scary mechanistic diagrams like this one. There'll be a few others. But we've got really a summary here. This is from the 8th edition. Really a summary here of all the different types of things that can happen to the cell during injury. And what could cause the injury? It could be UV radiation. It could be a loss of blood flow. It could be a toxic chemical. It could be an irritant. Okay? What could cause injury to the cell? It could be age, right? It could be trauma, physical trauma. Like all of these things are the stimuli that can manifest themselves down at the cellular level where we lose the ability to make energy, for example, the far left. If you can't make energy, you have many different downstream events that the cell is compromised with. Primarily, your sodium, potassium, ATPase pump. You guys remember that one? It runs off of ATP. If you can't maintain that pump, you can't move those ions in their correct direction and you don't create a gradient. If you lose the membrane itself, right, the plasma membrane, now you've got challenges to the mitochondria, the plasma membrane itself, and we get disruption of lysosomes that are inside that contain enzymes. If those lysosomes rupture their package, their outer envelope, and dumps all those enzymes into the cell, now they start chewing up things intracellular. If we damage the cytoskeleton, that also causes membrane damage. And then DNA damage. We can start accumulating misfolded proteins that are non-functional. They won't do the types of things that we need them to do anymore. Okay? Those proteins could be important in transcription or translation. Those proteins could be important in cellular signaling, cellular motility, right? Those proteins could be important in cellular shape, like the actin cytoskeleton. So we look at the different responses that the cell can have. We've got responses that the cell can do on its own, which is called autophagy. And then we have responses that the cell does in response to neighboring cells, or what's called heterophagy. Right? And with autophagy, which we see on the sort of left side of this diagram, you got this line down the middle. The cell itself might actually recycle and then exocytose some of its own organelles or tissues, right? And this could be in a apoptotic type of mechanism. Or in heterophagy, the cell might actually consume some particle that another cell released and bring it in as a ingested particle in a phagocytic vacuole, fuse it with the lysosome. Now you call it a phagolysosome, break it down into constituent parts and exocytose it or use it for itself. Right? So two kind of completely different responses that can take place. When we look at the damage that's occurring and the cause being, say, hypoxia, like over here where we talked about blood flow being compromised, typical causes of hypoxia are ischemia. And so let's define these two. What is ischemia? What's the difference between ischemia and hypoxia? Anybody know? Back up here?
Ischemia is blockage of blood flow, and then hypoxia is just the level of oxygen, which is usually caused by ischemia.
Very good. So ischemia is a restriction in blood flow or blood supply, and hypoxia is talking about the levels of oxygen levels in the tissue. And usually hypoxia is caused because of ischemia, where there's a low blood supply, but not necessarily always. Okay? So we've seen these adaptations. We're back to our kidney tubule example, remember? So these are our renal tubules, and we see that we reduce blood flow and we start getting necrotic changes. And we get adaptations that take place over time. So how does this happen mechanistically? I said that in that previous slide, and that's like the second or third time that we've talked about it today. We've talked about this particular histologic example a couple of times. I've shown it to you like 3 different ways. That's usually a hint, okay? When professors repeat themselves, they're either becoming senile or they're trying to emphasize an important point that you should remember, okay? So hopefully it's the latter of the two. So this should be an important hint that you should study this. But what I want to unpack is what's going on behind it, okay? And like what was brought up in the back of the room, here we've got low blood flow because you can appreciate this blood vessel has this blockage. And if this blockage happens, now there's reduced blood flows to the area, ischemia. If blood flow goes down to the area, we have low oxygenation. We have hypoxia. We have hypoxia at the level of the tissue. This is also what's happening in a myocardial or in the brain or in kidney or in liver or anywhere else. And if we go into the cell and we look at what's happening at the level of the mitochondria, mitochondria rely on that oxygen molecule in order for oxidative phosphorylation and the generation of significant amounts of ATP. So, at the level of the mitochondria, oxidative phosphorylation is compromised if you decrease blood flow, right? If you lower blood flow, you decrease oxidative phosphorylation, you reduce significantly the amount of ATP that you can make. Now, some tissues like the heart and others will compensate for the reduction in oxidative phosphorylation, and they'll ramp up glycolytic production of ATP. But can that last as a fuel source for a long period of time? No. If you remember back to basic bio classes, right? And this is like, I know this hurts a little bit, but if you think about like, why was I learning all that crap? You're like, I don't even remember it. Well, you were learning it because now you're about to apply it. And so one of my favorite things about these classes as you get up in your education is you start seeing the benefit of why you learned something and why you memorize it. Because now we get the application. Okay? So if it's a little rusty, and that's something you need to go over in SI, that's a great place. He kept saying oxidative phosphorylation. I don't remember that. Just remember it makes like 30-something ATP, right? And glycolysis makes like 4. Okay? And if you don't have oxygen present, you don't make your 34 or 36 ATP molecules, depending on how you count. Right? So if you lose ATP, remember your sodium-potassium pump? It's gone. Now you have this massive influx of calcium, water, and sodium. You have a massive efflux of potassium. You get swelling. If sodium rushes into the cell, then water is going to follow, and that's where the swelling happens, right? So we're talking about cellular swelling. The water magically just comes in? No. It follows the sodium. Why does the sodium go there? Because you're not pumping it out anymore. Why aren't you pumping it out anymore? Because you're not making ATP. How come I'm not making ATP? Because you don't have any oxygen. What happened to the oxygen? You lost your blood supply. Does that make sense? Okay. It's kind of cool when you think about it. Like you just integrated 4 semesters of work in one side of this diagram. It's kind of a cool diagram. It's scary, I get it, but if you walk through it carefully and you can explain all of this and it makes sense, you're going to be ready for that exam. Okay, let's look at this one. If you lose ATP, because there's 2 more pathways, you lose ATP, go down the middle pathway. Now you compensate with anaerobic, without oxygen, glycolysis to make 4 ATP. Woohoo! But that's all you get. As you make glycolysis, or as you make ATP using glycolytic pathways, you deplete your glycogen supplies. That's the storage form of glucose, remember that. So you burn up your glycogen, you byproduct or you make lactic acid. That's the byproduct of glycolysis. Without oxygen, you don't create any more pyruvic acid to go into the Krebs cycle. You guys remember that? You just increase the amount of lactic acid that's present, and now all of a sudden you've dropped pH. You've made it very acidic. Okay, so if you're back to the weight room, if you're in that dumbbell situation, like on rep 45, doesn't really matter what the weight is, just do 45 of them. You'll feel the effects of pH. Okay, that's the accumulation of lactic acid. pH drops, that causes the DNA material to start to clump. In the presence of low pH, you start compromising your DNA. Okay, lastly, let's see what happens to proteins. Well, you lose the attachment of ribosomes if you have not enough ATP. It's an ATP-dependent process. Ribosomes detach. Now you can't actually make proteins because ribosomes, remember back to basic introductory bio, ribosomes are those parts of the organelles that help you manufacture your proteins. Okay? So blood flow is pretty important. And it goes all the way into the cell and into the nucleus, the effects of a reduction in blood flow. So keep your blood vessels healthy, right? That's the take-home message. Questions on this slide? I just threw like 3 years of biology at you at once, okay? Some of you, I saw the light bulbs going off, and it's like kind of cool. From this, that's the paycheck, like from this side of the room. When the light bulbs go off, you're like, cool, like they got it. Some of you are like, oh, poop, I thought I remember that, but not quite there, right? So that's where SI is. Let's go over some of those things, and let's talk about what are some of the things that maybe you need to refresh on. Okay, calcium. We talked over here on this slide that we've got an influx of calcium, and I honed in on sodium and water, but let's talk about why an influx of calcium is quote-unquote bad. Okay, I thought calcium was good, like I'm supposed to eat cheese and take my calcium supplements, or at least mom is, right? Why is calcium inside the cell in high amounts bad? So here's another mechanistic pathway that we're going to walk through. I know these look scary, but if you just walk them step by step, they actually make a lot of sense. Okay, so number one, you get an influx of calcium, right? We talked from the last slide. Well, an increase in cytosolic calcium, or calcium inside the cell, that starts to trigger ATPases, phospholipases, proteases, and endonucleases. All of these are enzymes. Anything ends in ACE is typically an enzyme, and that means it's a protein. Okay? So calcium triggers all of these enzymes to be turned on. Now, an ATPase, you lower your ATP that's functional. Phospholipase actually chews up the membrane. Protease actually breaks down proteins. It degrades proteins like the cytoskeleton, which is like the framework that holds the cell walls up. Right? It's like you crawl in your attic and you see all the trusses and all of the work inside the attic behind all of the drywall. Like that's what the cytoskeleton is that's made up of actin. Those are like the 2x4s. So it chews those up, these proteases. The endonucleases, they move into the nucleus and they start chewing up the chromatin. All right. Earlier in the lecture we talked, and I alluded to acetaminophen poisoning. And then like one of you asked for Tylenol at the break, which is kind of ironic, right? Someone's not feeling well and kind of needs some Tylenol. But what we're here to talk about is reactive oxygen species, and then we're going to talk next about acetaminophen poisoning, like we alluded to in the beginning of the lecture. So we're trying to wind up what's happening and what's going on. And this mechanistic slide is talking to you about how free radicals form. Okay? So this is at the level of the mitochondria. So this box right here is the organelle of the mitochondria. And the mitochondrion responds to different types of stresses. So you can see over here the stress on the left, inflammation, radiation, chemicals, and even reperfusion injury. So if you turn blood flow off to an area and then you reestablish blood flow to the area, that's called reperfusing it. And when a tissue is without oxygen for a period of time, and then you open up the gates of blood flow and you reestablish oxygen, there's some damage that can take place. There's reactive oxygen species that can form. And so if we look inside of the mitochondrion, what takes place is oxygen forms a superoxide. This superoxide transfers into hydrogen peroxide, and through this Fenton reaction, you end up with a hydroxyl free radical. And this is your reactive oxygen species. This is highly reactive, meaning that it wants to oxidize lots of other things that it finds. Anything that it can come in contact with, it wants to oxidize. So your body has a way to manage this. And the way that it manages this is on the lower right, the removal of free radicals. It's not by eating blueberries, okay, although that can help. Your body actually has antioxidant mechanisms to combat the formation of these free radicals. Because we see inflammation, we see radiation, and we come in contact with chemicals like acetaminophen all the time, okay? Not that everyone's taking acetaminophen every day, but you're exposed to chemicals in your water, in your food, right? You're like, nope, I only shop at Sprouts. It's like, well, right, there's probably some cleaning supply on the floor that you're breathing from. Sorry, okay? So, SOD, superoxide dismutase, is found in the mitochondria, and it converts this superoxide to hydrogen peroxide. Glutathione peroxidase converts this free radical to hydrogen peroxide, like this free radical right here. And then catalase converts the hydrogen peroxide back into water and oxygen. Bless you. So water and oxygen is the output and how your body manages these free radicals. Now, if the body doesn't handle these free radicals well, and they stick around, then you have this cascade of pathological events that can ensue, right? So if you don't scavenge up these reactive oxygen species into benign substances like water and oxygen through the activities of these different enzymes, these antioxidant mechanisms in the mitochondria, then you're left with this list of problems. And so ROSs, They oxidize fatty acids, right? When they oxidize these fatty acids, they generate all sorts of disruptions to like organelles and plasma membranes. They oxidize proteins. As they oxidize the protein, it loses its function. It no longer works. As it oxidizes DNA, now you get mutations. And mutations are really bad, right? If they can't be corrected, or if there's a break in the DNA, it won't be replicated at all. But if it's a mutation, it actually might be a cancerous mutation. So we don't want these free radicals floating around. We want to be able to gobble them up, and most oftentimes we do. But this process here, want to bet, its effectiveness as we get older goes up or goes down? It goes down. Your ability to neutralize free radicals diminishes as we age. And if there's any underlying disease, your ability to manage free radical formation may also be compromised. It's not just age, it could be trauma, right? It could be genetic defect. It could be other chemicals that are coming in contact with the tissue. Yes, sir?
So a lot of what would they consider oxygen by itself oxygen?
Oxygen itself?
Oxygen to be because of its role in all this.
So yeah, it's a good point. I mean, so would oxygen be listed as a bad compound? Well, it's kind of at the top of the slide, right? That's how you generate all these free radicals. But so one could argue that oxygen could be considered to be problematic, but oxygen is obviously really important physiologically. And the other way to argue this is it isn't the oxygen that's a problem necessarily. It's the output of this Fenton reaction in a free radical, but your body has ways to manage these free radicals. And what I'm going to allude to for next week is these free radicals can become very effective defense mechanisms. So for example, macrophages in your body, this isn't this week, but macrophages in your body make these reactive oxygen species, and they use them to go kill bacteria that they come in contact with. So because this is potentially a weapon, and you want to be able to manage it carefully, right? But there are other cell types like macrophages, phagocytic macrophages, and they're like sentinel cells in the body. They're like the army that's looking for the bad invaders. And when they come in contact with a bacterial cell, they'll engulf it, and they'll fuse a lysosome with a phagosome. The lysosome has these free radicals in it, and the phagosome has the bacteria, and it's like, right? All inside the inside of the cell. And there's like that sound effect right there. It's really cool. Yes?
So, when you say species of oxygen, like, what do you mean species? Is it like oxygen elements?
Yeah, so this is just a term, reactive oxygen species. It's just a term that's in the literature that's describing a byproduct of oxygen that's unstable. And so maybe it's the terminology of species because it wants to oxidize something else and form a new entity. But usually what it's going to form over here when it oxidizes is not something very favorable. Okay, our last example for today is going to be this slide. This is where we're going to finish. Okay, so I promise that I'm not going to rush. And then we'll pick it up next week where I left off, okay? You may have some questions on Friday on the stuff that I didn't quite get to yet. Just kind of fair warning. So you probably want to look at those last like 5 slides and just understand what they look like. And you know, we didn't get a chance to cover them. But the last thing that I want to talk about is acetaminophen poisoning. So this is an example of liver necrosis. It's like, why are we talking about this? This is an example of liver necrosis. Okay? It also happens to be the #1 overdose problem in the Western world. Okay? And unfortunately, the population that's typically affected are kids. And the most common problem is cold medicine, like pediatric cold medicine. So kid's got a fever, doesn't feel well, mom or dad, meaning well, gives a all-in-one cold medicine, like a triaminic, right, or like a Dimetapp cold medicine, or there's all sorts of different types. Some of you that have kids are like, yeah. Some of you that don't have kids, you'll get there. Okay. And what they don't realize is a lot of those cold medicines have an analgesic and a fever reducer in it in the form of Tylenol, or the active form of Tylenol, which is acetaminophen. And it's very effective, it works very well. But then what they don't realize is when the kids said they don't feel good in the morning and they gave it in the middle of the night, they give them another round of Tylenol, but not the nighttime cold medicine. And then they give it to them again like at lunch and then like right before nap. And then they do that for 2 days, and now they've had Tylenol around the clock, and what's happening at the liver is the hepatocytes detoxify Tylenol through this process by conjugating it with sulfate. And that's the main way that it detoxifies it, is by binding it with sulfate. Secondly, it conjugates it with glucuronide. And the first two processes account for about 90% of Tylenol metabolism: sulfate and glucuronide binding. The third pathway, which is this cytochrome P450 oxidase, this is metabolism using this cytochrome P450. This oxidizes the rest of the 10% of acetaminophen. But the problem here is there's a metabolite, an intermediate, this NAPQI. And so it goes from acetaminophen to NAPQI through cytochrome P450 oxidase. And that NAPQI is actually an hepatotoxin. And so when this hepatotoxin is present, it's directly toxic to the liver. And it doesn't ultimately get excreted by the kidneys bound to glutathione because it gets stuck in the liver. And so this is what you see. Here's healthy hepatocyte tissue, and here's necrotic tissue on the lower right. And this is the delineation. So really what it is as long as you're giving enough time between doses of acetaminophen, you're allowing the acetaminophen to clear the system using these three processes. And the first two processes are not really problematic at all. Bound to sulfate or glucuronide. It's the P450 oxidase system because of this NAPQI intermediate that causes this necrosis of the liver that happens. It can happen within a 48-hour period from the first dose of Tylenol. Okay? All right, so we're going to pause there. We'll pick it up on this slide next week. Don't forget the quiz.